Hi, Dr. Telji reporting live from Jacksonville for Group 1, Case Scenario 1. Let's find out what happened to patient SM. So SM is a 60-year-old African-American male who was just diagnosed with upper extremity DVT. To fix this, he was prescribed warfarin 5 milligrams every day for a total of 35 milligrams a week. For the last month, his INR has been within range of 2 to 3. However, the last week his INR was 1.4. So to correct this, the on-call provider advised the patient to take 2 3 milligram warfarins and follow up in a week to recheck his INR. This led to the sentinel event, an INR of 6 at the follow-up with no signs of bleeding. From here, the pharmacist advised to hold 2 doses and then to take 5 milligrams of warfarin every day, however on Monday and Friday to take half the dose, for a total of 30 milligrams of warfarin per week. He then wanted to recheck the INR in 48 hours. At this follow-up, the patient reported being very confused about his medication regimen and said he had been taking the 3 milligram and the 5 milligram regimen as prescribed, leading to a total of 72 milligrams of warfarin per week. Let's do a root cause analysis to figure out what happened in our patient scenario. The first event was when the INR was 1.4. This is probably what happened.
Oh wow, Mr. Morris's INR is down to 1.4 when it's usually in a range of 2 to 3. I better up his dose. Hi pharmacy, this is Dr. Burdell at the Coumadin Clinic, and I'm calling about Mr. Morris, and I would like to up his dose to warfarin 3 milligram tablets, 2 tablets a day. Thank you.
In this scenario, we don't know why the INR was 1.4. Could this have been due to a changed diet in the patient or possibly a missed dose? This is something we need to find out. On a similar note, there's a lack of interprofessional communication here, and we're not sure was this interaction properly documented for the on-call provider to know the interaction between the patient and the pharmacist here. Similarly, we need to know, is the patient aware that they need to discontinue the 5 milligrams of warfarin when they initiate the 6 milligrams a day? We would not want our patient to be on 11 milligrams of warfarin a day. With these pitfalls in communication, it led to our sentinel event, our patient having an INR of 6. Let's see what happened next.
Hi, Mr. Morris. This is Dr. Akbari, the pharmacist. Yeah, your INR is back and it's above goal. It's at 6 right now. So I want you to hold the next 2 doses and then start back on the 5 milligram warfarin every day, except for Monday and Friday, just take half, and then come back in 48 hours for a recheck. Okay, thanks.
Again, this was another missed opportunity for the healthcare team to figure out why the INR jumped all the way up to 6. If the patient had been taking 6 milligrams a day as opposed to the 5 milligrams a day he was taking initially, that 1 milligram increase would not have caused the INR to jump from 1.4 to 6. So this could have been avoided right here from the get-go. Again, a missed opportunity. In a similar fashion, when the pharmacist advised to hold 2 doses of warfarin and then continue 5 milligrams every day except Monday and Friday to do half a dose, this would have been a great opportunity for the teach-back method. It would be very easy for a patient to be confused about which doses to take, and it would have been great to have some clarification on this matter. Let's delve into the mind of the patient.
Hi, I'm the patient. I'm on 3 milligrams warfarin, 5 milligrams warfarin. I don't know what I'm supposed to do. This is so difficult.
So here we have our 3 experts to analyze the root cause of this scenario. So we have Dr. Zhang, Dr. Akbari, and Dr. Burdell here to discuss further. Now, other than encouraging the patient to take a little bit more initiative when they have questions on their patient care, what else would you guys recommend so that we can change and better the patient outcome for this specific scenario?
I think in this case, increased communication could be utilized. This will really prevent us from making medical errors like this and really figure out what was the cause. And when we're probing the patient about his INR being 1.4 instead of his normal goal at 2 to 3, this is a really good opportunity to interview the patient and really deeper into what is the problem for his lowering in INR.
What questions did you ask?
I will ask him if he had any recent changes in his diet, such as his intakes in his greens, if he's having any adherence issue, any missed dose. Any of these causes would have been easily fixed, and then that could have been identified, and he wouldn't have needed to increase his dose. And that communication could prevented him from taking too much warfarin and with his dramatic increase in INR.
Yeah,
Yeah,
I
I
definitely
agree.
agree with that. And another pitfall that I noticed was that the on-call provider, when he saw that the INR dropped from the goal 3 to 1.4, he immediately called in an increase in the patient's dose, rather than talking to the pharmacist and figuring out, why did the INR decrease from 2 to 3 to 1.4. This interprofessional communication could really prevent these kind of errors from happening.
I agree.
I agree too.
Right, and I think also when the patient came back with an INR of 6, we had another opportunity there to ask questions. His INR jumped from 1.4 to 6, and that's a dramatic jump, and it shouldn't jump that high. It would be a good signal because increasing from 5 milligrams to 6 milligrams a day, that would be a signal because it shouldn't cause that much of a hike.
It's a lot.
So what do you guys think then that we can implement in order to avoid this?
So I think we'll all agree that we need an intervention here to really prevent future errors like this to happen again. And I think the CPOE would have been a good program. It would really help flag physicians and pharmacists when new therapies or changes in therapy occurs. And the system would remind the physicians and pharmacists to talk to the patients. It will be a requirement for them to counsel patients and use teach back methods to understand if the patient clearly knows what's the changes in their therapy and if they know what's going on, and better communication, better scholar max skills and training, all of that could have helped to prevent these errors from happening.
Yes.
I agree. I think with these recommendations, let's play a scenario of what could have happened with all of you guys' great recommendations for our patient.
Sounds good.
Sounds good.
Hey, Dr. John, this is Dr. Tarsak. Do you have a few minutes?
Yes, I do.
All right, I was just in the clinic with Mr. Morris,
Mhm.
and I noticed his INR was 1.4,
Mhm.
and we changed the dose to he normally takes 5 milligrams a day, and we wanted to change it to 6 milligrams a day. However, I did a med rec with him, and I found out that it's usually 2 to 3 when he comes in, but because of the holidays, he's had a lot of leftover broccoli casserole with all the families he's had in town. He's missed a couple doses. So he's had a lot of extra vitamin K and he's missed a few doses. So I would actually recommend instead of changing his dose, we should leave it at 5 milligrams for a week. I've already counseled him on the fact that it's really important not to miss a dose and a consistent diet. He clearly understood. He didn't realize that before. He said he'll do better with that. So we'll have him come back in a week and recheck his INR. And if it's still low, then maybe we can consider raising that dose.
Well, I didn't catch that on his chart. I wasn't aware that he was taking all these extra vegetables and not taking his doses properly. And I agree with you with that. We should keep him on his current dose and see how he goes from there. And we will follow up in a week.
Sweet, sounds
Well,
good.
thank you so much.
I will let him know.
Thank you.